All right, so welcome to Respiratory Disorders Lecture with me, Miss Gilbert. Our course objectives are going to be quite similar again, so we're going to apply our patho. We're going to teach clients how to manage these respiratory problems, and we're going to talk about some common drugs and other management strategies. We're going to implement some nursing interventions, collaborate with our interprofessional team, and then help our clients and family cope with the psychosocial impact of these disorders. So I'm going to first start with asthma. I'm going to break up these lectures individually. So there'll be like a part 1 for asthma, part 2 for COPD, and things like that. That way you can watch them individually and not have to scroll through them. So first, asthma. What is asthma? Asthma is a chronic disease in which a reversible airway obstruction occurs. It's usually an intermittent issue, but when it does, it reduces airflow. So you see in this picture on the left, the surrounding smooth muscle layer. Then we have a cartilage ring and a mucous membrane lining, and then the lumen where our air actually freely moves. This is our normal bronchial airway, whatever you want to call it. Okay, but you see now at the bottom pictures with B, C, D, and E, this is what happens. So then we have the mucous membrane lining where it swells up in B. We have C where everything is okay and normal-ish, but it's still a little concerning with that red mucous membrane, but we still have an airway. Whereas with D, it is so swollen and constricted that we're not moving any air. And then in E, where we have just some mucus stuck in there. And so then when we have mucus on the lining, then we have also an obstruction of the available airway tube. So we can't move our air as much. Now, as you can imagine, when we have a reduction of airflow, we're going to have difficulty breathing. Now, asthma is usually due to a trigger, and these triggers clients have little control over. It can be an allergen or an irritant, such as cold air. They just walk into a building, the air is too cold for their lungs to react appropriately. Essentially, asthma is an overreaction to an allergy. They overreact their immune system. So cold air, dry air, or fine airborne particles just can be too irritating and triggers this cyclic effect and causes inflammatory issues, and then now their airway's closed. Could be a microorganism or upper respiratory illness. It could just be that they took an aspirin or an NSAID and they're allergic to it and they didn't know. And that anti-inflammatory effect, again, their body just overreacts to it because these are leukotriene modifiers. Exercise can also trigger reflux because of the acidic irritation to the esophagus. Can be pre-existing tissue sensitivity in the esophagus, which then irritates the tissue down in the bronchioles and triggers this reaction again. And there's also where we just haven't figured out the reason, an unknown reason that they're just overreacting. Their lungs are overreacting. And again, they don't have control over this. So an asthma attack can result from one or both of the following ways, either through an obstruction or narrowing, as like we briefly went through in these pictures. So an obstruction can be due to an inflammatory process. So what happens, the histamine is released, leukotrienes or eotaxins, which then cause the vessel to dilate and capillary leakage. That capillary leakage leads to mucous membrane swelling, mucus production, and then it increases the narrowing of the airway. Then we have narrowing of the airway due to a tissue sensitivity and bronchoconstriction, so like with D. So this is a stimulation of the nerve fibers that causes constriction of the smooth muscle. Then we have where both are occurring. So we have an inflammatory reaction that just causes the constriction. The asthma can occur at any age. It's more common in urban settings and in rural settings, and it's more common in pediatrics as well. But it can occur onset at any age. So why is asthma a problem? With that severe airway obstruction, we reduce our ability to exchange our oxygen and CO2. So our gas exchange is being impaired. As a result, of course, this can be fatal. Per year in the US, there's 3,630 deaths related to asthma attack. This is especially the case in older adults. When asthma is well controlled, airway changes can be temporary and reversible, but with poor control, that chronic inflammation can lead to airway damage and alter the cellular regulation. So those that have frequent asthma attacks can cause changes to their mucosa and smooth muscle in the bronchiole, and it leads to more sensitivity and more frequent asthma attacks. So this is why it's important for community and home parental education about you really do need these inhalers to prevent these attacks. It's not wait for an attack to happen, come to the emergency room and be treated, because they're going to be more sensitive in the long run, and you're going to increase their mortality rate the more attacks that they have. So important education here. More than 50 different gene variations are associated with asthma, as well as gene variations that control drug therapy impact. So not all drugs affect all clients the same way, and it's genetic. It can be managed at home or in the community, but acute exacerbations may require an emergency department visit or even an ICU stay. So what does this look like? Clients with mild to moderate asthma may have no symptoms between those asthma attacks, but during an acute episode, we can see audible, but our clients will exhibit audible wheezing, which is first heard loudest on exhalation. So when they exhale, we hear that wheeze. When we get to the point of a wheeze on inhalation, then we have a severe airway obstruction, and that's where you're concerned with stridor. Also, these clients may have an increase in respiratory rate as a compensation, trying to increase their oxygen delivery. They can have coughing as well due to that inflammatory response. Use of accessory muscles, so then they're having like retractions in between their muscle and their ribs. It can be at the sternum or at suprasternal notches as well. Longer breathing cycles can also occur due to the prolonged exhalation phase, but this requires more effort, and so they need to be intervened on immediately when you are noticing this in place. Again, remember, respiratory system compensation does not last for very long, so we don't have long before it gives up. This may also be seen as them having trouble speaking for more than just a few words between breaths. Hypoxia can also be noted, which is, of course, the low O2 saturation and the cyanotic mucosa in nail beds. As compensation, cardiovascular-wise, their heart rate may increase but their change in cognition or consciousness may also occur due to that hypoxic state. Severe or chronic asthmatic clients may have a rounded chest shape or a barrel chest appearance due to air trapping. And so you see this in the image down below. So a normal client is this picture in A, whereas a severe or chronic asthmatic, and when we get to COPD, you'll also note that this AP diameter increases. So they get that barrel chest. Not so much wide as it is front to back. Their diaphragm flattens and it increases the space between the ribs as they're trying to find areas to get oxygen, because all of this is trapped CO2. So what kind of labs are consistent with asthma attacks? So first, diagnostic wise, we're going to look at our arterial blood gas, ABGs. So knowing our normals here again is going to be important. We have an O2 stat that may be decreased during an attack, and our CO2, remember respiratory is what we're looking at. Our CO2 may be decreased in the early phases due to the increased breathing rate and depth, the effort of our breathing. But then as the attack continues, our CO2 is actually going to increase because it's going to be retained and trapped. Okay, so you'll see here at this top image with the ABG for an acute asthma, the pH, PO2, and CO2. The acute is in like the early stages of an attack, okay? But remember, as it continues to go on, or with chronic asthma, they may get to the point where their CO2 becomes trapped and therefore is increased. Lab-wise, they're going to show an elevation in their eosinophils and immunoglobulin E. These are usually associated with the allergic inflammatory response related to asthma. And then we have pulmonary function tests, PFTs. These are going to be important. So we have a spirometry measurement is going to give us these different curves and capacities. So we have a forced vital capacity. So your complete vital, meaning everything. You have your forced expiratory volume, how much we can exhale, and the peak expiratory flow. So the height of that expiratory phase, when we are giving out the most of that force. Our forced expiratory volume and peak expiratory flow can show a decrease of 15 to 20% below the expected value when we're testing a client that has asthma. They don't even have to be having an attack, but their expiratory volume and flow, they're not able to get all of that out as effectively with asthmatic clients. So asthma is usually diagnosed then as a result of this, because when there's a 12% increase with treatment of bronchodilators. So this means that they had a PFT performed, then as their baseline, and then they received treatment of a bronchodilator in order to open up that airway, right? Then they performed a PFT test afterwards, and it shows that, oh, that bronchodilator actually worked and opened up their airway. So they have more capacity or potential capacity if they were on a bronchodilator, which means that they have some sort of chronic obstruction or inflammatory process. It's probably asthma. So then they diagnose them with asthma, okay? All right, so how do we care for these asthmatic clients? This is going to be based off of the step category that we'll get to on the next slide, but it's based on the severity and it's going to determine our treatment. So first we need to understand what severity our asthmatic clients are in. So what level of control is what we're essentially asking. So then we do this based off of their symptoms. They are considered well controlled if they have none of the following symptoms, partly controlled if they have one or two, and they are considered not controlled if they have three or all four of these. So we're looking at daytime symptoms of wheezing, dyspnea, or coughing that may be present more than twice a week. If they are waking from sleep with wheezing, dyspnea, and or coughing. If they are using their rescue drug inhaler more than twice a week, or the number of times per week an activity was then limited or stopped by their asthma symptoms. So then now that we have a good understanding of like where our client is in their control, then we know kind of where they are with their medications. If they're being well controlled, then we don't need to change their step. Whereas if they're being partly or uncontrolled, we need to modify their steps. But things that we can do in the immediate treatment is that if their oxygen level is low, we can immediately intervene on that. So we can provide a mask or nasal cannula during the acute attack, and then we may even progress to a high flow when bronchospasms are quite severe. So based on their symptoms, they may only need like a daily and then like an as needed exacerbation treatment. Whereas those that are well controlled, ideally, they don't necessarily need a daily preventative medication. They just need their exacerbatory medication. So drug therapy options for these asthmatic clients, this is the step thing that I was talking about. So our options are going to be in these two broad categories of either a bronchodilator or a anti-inflammatory. So here's our steps. So our step 1, step 2, step 3, step 4, and step 5 is where your book leaves off, but there is technically a step 6. And this is based off of the STEPS system for asthmatic management from lots and lots of research. So persistent daily medication usage of asthma are going to be any of these categories of step 2 or above. Those that are considered with intermittent asthma are going to be those on step 1. So this also suggests that like anyone that's on step 2 through 4 should consider allergen immunotherapy treatment as well as drug therapy. But as you can see, we start initially with a low dose inhaled corticosteroid. That's what this ICS stands for. So this is going to be our preventative. And then we'll add in like a bronchodilator for our exacerbatory immediate relief medications. As we progress in our severity or our uncontrolled state, we're going to step up. That's what we consider step up. If we have any issues that we need to control more, or if we're being well controlled, then we can consider stepping down off of some medications. But this is only the case when asthma has been well controlled for at least 3 months. So if someone is having an increase in their asthma attacks, we're going to look at first environmental factors, any triggers that we can probably avoid, and any comorbid conditions that may be exacerbating it, like the reflux, remember. So we first start with an inhaled corticosteroid to help with that inflammatory reaction. And then we'll add a long-acting beta agonist like salmeterol or formoterol. And then as we progress and get worse, we'll go to a medium dose inhaled corticosteroid. And then on step 5, a high dose inhaled corticosteroid. And then on step 6, we're on a high dose inhaled corticosteroid, a long-acting bronchodilator, as well as a oral corticosteroid. So essentially, just understand that with stepping up, you're increasing the severity, trying to get more control on their asthma. And stepping down means that they have been well controlled for some time, and maybe we can come off of some medications. Also understand the purpose of these different types of medications. So the bronchodilators are going to be to open up that airway. The long-acting beta agonists versus the short-acting beta agonists are also things that you're going to need to know the difference between. The short-acting are going to be those acute relief medications, acute asthma attacks. Whereas the long-acting ones are going to be more for that preventative of the bronchodilation. Okay. And then with anti-inflammatories is decreasing that inflammatory response with corticosteroids, chromones, leukotriene modifiers like Monteclast, and monoclonal antibodies like these Zumabs. Okay. So what education can we give to these asthmatic clients? First and foremost are going to be the medications. We are going to look at those controlled therapy drugs in order to prevent, hopefully, as many asthma attacks as we can. So those that are the preventative medications on those step categories, they should be used every day, regardless of symptoms. Skipping those preventative drugs are going to increase their likelihood of asthma attacks and cause that inflammatory cycle where we are increasing their sensitivity and more likely for worsening acute attacks in the future, which then increase the mortality rate. So education is quite important. That I know they're expensive, and you might feel good today and want to try to skip your inhaler dose, but you really should not. Reliever drugs, are also known as rescue drugs, are used to stop a current attack. So these are not meant to be the end-all be-all for non-well-controlled clients. Again, they're very expensive, especially if you're on like step 3 or 4 where you have multiple types of inhalers. And families have to choose, and so then they choose to only pay for the rescue drug, the albuterol, and just wait for an attack to happen and try to stop it during the attack instead of preventing it. Again, this increases the mortality rate, sensitivities, and likelihood of worsening attack the next time. We really don't want that as a habit for their body at young ages. So again, it can be very hard, but these should not be the only treatment, ideally, unless you're very well controlled on that step 1 and you have intermittent asthma. So these are, again, different than your control therapy drugs because the control are more of the preventative versus the rescue are for now. Also, education we need to talk about is how to use an inhaler, on how to take in that breath while we're pressing down the button. Also about education about how to shake it, how to change it out. those that are like the corticosteroids, where we need to actually rinse to prevent that thrush on our mouth, and things like that, specific to our medications again, on the different types of inhalers. There'll be another short video about respiratory management with like different devices and things like that, and I'll show you some inhalers and the spacer. Education about the spacer is also going to be important because it only fits these like traditional style inhalers that you see like in this green one in the picture, but they don't fit like your inhaled corticosteroids, like your Montolast and things like that. So making sure that they know how to use a spacer when they need a spacer to provide that extra moment or so that the medication is expelled into that chamber, which gives them that extra few seconds since it's held there for them to actually take that deep breath in, and then holding their breath while their lungs are inflated to get that medication all the way down. We also need to give them education about if they are to use a bronchodilator in combination therapy of any of their other inhalers, make sure that they use that bronchodilator first. That bronchodilator getting down to the bottom part of those lungs, opening up everything, will increase the effectiveness of your other medication, like your inhaled corticosteroid or something. So that is other proper education for our clients. Regular exercise is actually recommended to strengthen muscles and promote gas exchange and perfusion in our asthmatic clients. I know a lot of parents and school systems seem to discourage the use of PE and extracurricular activities for clients that have asthma because they're worried about triggering. But they actually still need to exercise. The issue is that they're being triggered because they're over exercised, and so not pushing them is going to be the main key, not just don't let them exercise. So adjusting the routine or the environment may be necessary for these asthmatic clients, but not to avoid exercising. Short-acting beta agonist may also be needed prior to an activity as like a preventative in these cases. Reducing stress and anxiety can also help reduce asthma attacks. Getting adequate rest and sleep. Clients should be educated on how to do their PEF on the spirometer twice daily. So this is going to be where we're looking at their red, yellow, and green zones. So again, I talk about this and show you one in the video in the respiratory management. But this is not like an incentive spirometer. Incentive spirometer meaning that there's a benefit, whereas this is more of a measurement. So we are measuring them baseline when they're not having attacks and giving them a goal. And we set this on the area of their spirometer with a green marker. So they're supposed to be measuring their PEF twice daily, preferably once in the morning and once in the evening, just to get a good, well-rounded assessment. Now, if they exhale, because remember this is expiratory flow, when they exhale and it did not hit their green zone, they need to know what to do. If it's yellow zone, they also need to know what to do, and red zone means emergency. This means that their airway is severely restricted and that they need to intervene immediately, either with their short-acting like albuterol or go to the emergency room. So education on this PEF is going to be very, very important. Any known triggers that the client knows that they have had an asthma reaction to, of course, avoid. And then education on like what symptoms are important to seek emergency care. Now, lastly, what concerns does asthma warrant? So, complications. We have status asthmaticus as well as respiratory failure. Status asthmaticus is a severe, life-threatening acute episode of airway obstruction that intensifies once it begins and does not often respond to usual therapy. So they're having an acute episode, they've used their bronchodilator, and they're still having an increase of airway obstruction. They usually arrive then to the emergency department with extremely labored breathing, wheezing, sometimes even stridor. They have the use of accessory muscles and distended neck veins due to the respiratory effort. If this is not reversed, it can develop into a pneumothorax and cardiac or respiratory arrest. We treat immediately with IV fluids, a potent systemic bronchodilator, and steroids, potentially even epinephrine, and then we're going to provide oxygen. Magnesium sulfate may also be used. This has been shown to increase the airway compliance and therefore making it easier and less of an effort for breathing. And then we also may need to prepare for an emergency intubation. If this airway obstruction is not immediately intervened and still not responding from our interventions, we need to save the airway by intubating. A sudden absence of wheezing may indicate a complete airway obstruction, and then we're going to need to save an airway. That if there's no more wheezing, that means there's no more air moving. Therefore, we need to make an airway. This may involve us creating a tracheostomy, where it's a surgical incision into the upper airway, like the trachea. When breathing improves, then we can treat them just like with any client that has asthma. If you want to know a little bit more about management specifically in children, in the ATI children's textbook on page 101, you can take a look there. And then we have respiratory failure. This is a persistent, well, it might have changed from 101 because that was the last year's text. So it's around there. Now for secondary, other concern about asthma is respiratory failure. And this is due to the persistent hypoxic state, or hypoxemic state, I should say, resulting in an acid-base imbalance. And therefore we need to prepare for intubation to save our airway and improve our gas exchange and providing mechanical ventilation. So these can get quite severe quite quickly. So again, this is where education not only for home management, but also of what symptoms does it mean that it's worsening and they need to come to the emergency room. Because again, there are just too many deaths per year for asthma related events. And it's not just in children, it's also older adults. So they've dealt with this. They should know, but they've become tired or not able to afford it. There's many different reasons, but important of reinforcing that education every time that they are seen at the hospital or the doctor's office is going to be important on saving not only their lungs in the long run, but also their lives. I'm going to move on to the next section in another video.